Fine. Good evening, everybody. Today is the second module of Allergy and Immunology workshop, and I welcome all of the participants, especially all the faculties who are present here. So, without wasting much time, I think we should start with Dr. Mahesh, who is presenting today on epidemiology of allergy and asthma. So, over to Dr. P. Mahesh. Please go ahead.
I'm happy to share my thoughts on epidemiology of asthma and allergic diseases. Specific emphasis on India. I'll be dealing with mainly the Indian studies. I'm Dr. Mahesh P.A. I work as professor in the Department of Respiratory Medicine in JSS Medical College in Mysore, India. Now, if you look at the scope of the talk today, we look at the burden of disease in adults and children. Briefly, we will look at the global burden of disease data, the ISAC data, the global asthma network data, the InSearch, which mainly looked at adults, and our own data from myself. We look at some of the important risk factors, very briefly, each one of them. We will look at genetics, the role of allergic rhinitis, the role of atopic, the role of air pollution, and the other risk factors that have been identified. So this was published in the Lancet, and Dr. Sandeep Salvi led the paper. And this looked at asthma and their sort of heterogeneity across different states in India from 1990 to 2016. And you find that the prevalence of asthma substantially increased over a period of 16 years. After that, it has plateaued to some extent. Now, this is something we looked at in 2019, again, the global burden of disease data in every state in India. We also looked at in different ages, less than 50 and more than 50, and in different gender, male as well as female. What is clear is that there is a substantial heterogeneity in the prevalence of asthma in different states in India. Now, the reason for this heterogeneity is not very clear. Is it because of differences in genetics? Is it because of differences in the environment? Is it because of differences in pollution? Is it because of differences in their diet? It's still not very clear. Is it because of differences in the density of the pollens as well as the some allergens? Because we find that Northeast, which have very high vegetation, we find that they have among the highest prevalence of asthma. They have very less pollution as compared to the rest of India. But if you see, the highest prevalence of asthma in India is present in the Northeast. Looked at the main multi-center studies which have used a uniform methodology is ISAC study, and now recently the global asthma network study. They looked at two particular age groups, 6 to 7-year-olds and 13 to 14-year-olds. So this is the data to look at the prevalence of asthma in different centers that were done in the ISAC study, and Mysore and Kolkata joined for the global asthma network study. They were not part of the ISAC study. Again, you find there is a wide variation in the prevalence over time and among different centers in different states. Again, as in adults, we are not very clear as to what could be the reasons for these heterogeneity, and a lot more studies, mechanistic studies are actually needed before we understand the reasons for these differences. Now, we did a study looking at what is the prevalence of rhinitis and asthma in India, and we've observed that in 2,000 children, every 5 years, starting from 1998, we found that the prevalence of rhinitis and asthma has been increasing at the rate of about 50% every 5 years. So that's a fairly high increase over time. In the recent Global Asthma Network study that has just come out, now this trend is showing the reversal. That's a very welcome sign. And one of the main reasons that has been postulated is that while earlier, 20 years ago, everyone wanted to have a house near the main road, these days, everyone wants to have a house away from the main roads in the residential areas where the traffic pollution is drastically reduced. And this phenomenon is seen across the low and middle income countries in the Global Asthma Network study and has been observed in India also. A lot of people now stay away from the highways. And I think for the first time, these large multi-center studies have shown that the prevalence of asthma can actually show a decrease, and staying away from the highways is one of the most important factors. Same thing we observed for the rhinitis as well. Now let us quickly look at some of the risk factors. And the most important risk factor for asthma, we all know, it is the genetics. The genes are there at birth, but it's the switching on of these genes that actually matter and cause the onset of disease. And the switching on of the disease happens due to the environment. So it is a gene environment interaction that actually leads to the onset of the disease. We see children as young as 1 month present with typical features of asthma. We see people presenting for the asthma first time at the age 80 or even more. But the genes are there at birth. It is only the timing when the genes are switched on. Again, a lot of work needs to happen in India as well as the rest of the world to find out why this is happening. Allergic rhinitis is one of the most important risk factors for the development of asthma. Atopy is also very, very important. We'll also briefly look at the effect of pollution and what are the other possible risk factors that have been identified from these studies. Now, the summary of various genetic studies in the Indian subcontinent, we did a review for the clinical and experimental allergies. I'm not going into the details of each of the genes, but the most important gene is the ADAM33 gene. And then we have a whole list of other genes, including the transcription factors, including typical cytokines and the receptors associated in TXO inflammation. So there's a whole lot of these genes, and we also looked at what are the gene variations. We have looked at in which population this has been studied. We have only selected those that have been found to be significant, and what type of a design was used. So these are all the various genes that were studied, and most of the studies, as you see, have used the case control study. Rarely they have used a family tree, and most of them are case control studies and have been studied both in the North Indian and the South Indian population. Again, these are the studies. So a whole lot of them, it is good, but we don't see a whole lot of whole genome sequence. It is very difficult. We have been involved with many studies looking at single nucleotide polymorphisms, but they are not always significant, though they have been shown to be very important in the animal models. And the main reason for that, it is not just one gene that is responsible for asthma. As you can see the big list, there's a whole lot of these genes that are relevant for asthma. And each family, we have been involved with whole genome sequencing with Dr. Anurag Agarwal from IGIP. And it is probably different for different families. The combination of genes that are harmful, that are protective, that lead to the onset of disease may be different for different families. So we need to really up the game and come up with a combination of these genes. Only such studies will be able to give a good input and a good understanding of why these genes matter. Again, these are all the lot of genes that are relevant and found significant in asthma. Now, rhinitis is one of the most important. 50% of people with rhinitis will develop asthma in their lifetime. Many studies have, longitudinal studies have shown, and we have found that most of our patients who develop asthma after the onset of rhinitis do so within the first 2 years. If you see children and young adults, almost nearing 80% of them will develop asthma within 2 years. So the timing for us to intervene to prevent asthma is very short. If you look at adults, it's possibly about 70%. So a lot of these people who have rhinitis are likely to have asthma or will develop asthma in the future, but the timing is quite short. So we looked at the various factors that could be relevant for the development of asthma in patients with rhinitis. So we found, again, family history is important. Sensitization to dust mites was important. If patients with rhinitis used nasal corticoids, then they had a protective effect in the prevention of asthma. Presence of atopy and the atopic march is an important risk factor for the development of asthma. Asthma comes later. GI symptoms, skin, food allergy. They tend to come before asthma in the usual atopic march. And one of the most important is a defective filaggrin in the skin, defective epithelium in the airways. Now, defective lipids such as sphingosine and ceramide in the skin and the abnormal cytokine response of the keratinocytes, both the skin and the airway epithelium release what is called as alarmins. That is the TSLP, IL-25, IL-33. Now, these are the main drivers for the development of airway inflammation. So a defective epidermal barrier complex or an epithelial barrier complex for the airways possibly leads to higher penetration of the allergens, interaction with the Langerhans cells in the skin and the dendritic cells in the airways, interaction with the T cells, leading to Th2 deviation in the skin as well as the airways. So this is a chapter we wrote to know what are all the different cells that are involved in the atopic march and the development of asthma. TSLP, that the thymic stromal lymphopoietin, is a very, very important mediator. And these are all the cells that are involved, and these are all the various effects of these various mediators that lead to the development of allergies and asthma. It's also important when we want to study why some people develop asthma and some don't. The environment is critical. If there is a pathogen-associated molecular patterns, PAMP-rich environment, then it leads to the exposure to the allergen, leads to the activation of Treg cells and Th1 cells. But you're looking at the PAMP-poor environment, then the exposure to the allergens is going to lead to the development of Th2 inflammation and a whole lot of these cytokines, a whole lot of these cells that are involved that can cause the disease, allergic disease. When we talk of an eosinophilic inflammation, it is not only with the allergen pathway. It's important to realize that it also comes with a non-allergic pathway. And that includes the pollutants, includes the microbes, the glycolipids, and the exposure, as we talked of alarmins. They lead to the innate lymphoid cell too. These are the transcription factors. And this is the prostaglandins. These are the different cells that are involved. Finally, this pathway also, though this is a non-allergic pathway, leads to an eosinophilic airway inflammation. So an airway inflammation can be allergic as well as non-allergic. If you look at the pollution, we did the study to look at whether pollutants are important. And as you see, this is the trends in asthma prevalence. But if you look at the NO2 as well as the SO2, while the asthma prevalence went on increasing, we found that the pollution had actually reduced. In 2003, there were new laws that were introduced, and therefore we found that most of the pollutants had reduced. But in contrast, the prevalence of asthma went on increasing. It did not show a reduction. So we postulated that it may not be really important. Again, this is what we found with PM10 as well, that while most of the pollutants reduced, asthma went on increasing, and therefore it is not a very linear relationship. Now, I wrote this editorial for Sandeep Salvi and his team's work to look at air pollution and asthma. Now, again, in their study also, it was found that the relationship is not very linear. They were not able to actually pick out why this is so. So one of the reasons is the effect of pollution on asthma. It's mediated by the BMI. In China, for a per quartile increase in PM 2.5, FEC decreases by 25 ml in normal people, but 120 ml in obese children. In a German birth cohort, a 3.37% reduction in FEV1 per quartile increase in NO2, which is a good marker for traffic-related air pollution in the obese children, but 2.87% reduction in underweight children as compared to children with normal BMI. Therefore, both obesity and malnutrition has an effect and mediate the effect of pollution on asthma. The least effect of air pollution on asthma and lung functions were seen in children with normal BMI. Both the obese children were susceptible and the malnourished children were susceptible. So it's important that BMI is one of the important mediators of this complex interaction of air pollution and asthma. In India, where malnutrition is still a significant problem and obesity is now becoming an epidemic, we can expect a greater and greater effect of air pollution on asthma. Now, some of the other risk factors found in the ISAC study as well as the INSERT studies, these are all the risk factors that have been studied. The smoking by the mother, the father, the sedentariness is important, exercise, older siblings, younger siblings, paracetamol was found to be relevant. Now, whether this is the horse or the carriage is an important one. They say paracetamol is important, but who will take more paracetamol when the child gets recurrent respiratory infections? Those are the children who are using the regular paracetamol. So whether it's the paracetamol or the reason, such as an infection, for why they took the paracetamol, that has not been, this is a Lancet paper, but it has not been discussed very well. My suspicion is that it's the viral infection. A lot of these viruses are known to trigger of asthma. This includes adenovirus, respiratory syncytial virus. We are seeing a lot of asthma after COVID. So it is the viruses that are more relevant and not paracetamol. It might take, the Lancet paper does say that it is paracetamol that is important. Then, of course, the indoor air pollution, whether it is used for cooking or heating, and is seen to be more important, especially young children, as compared to the outdoor air pollution. Damp areas, actually important for the rhinitis, but could not find so much data for asthma. Gender, antibiotics, prematurity in birth, breastfeeding, birth weight, whether it's underweight, overweight, obese. These are all the different risk factors that have been studied, and some of them have been found to be relevant for asthma. If you look at the risk factors for 13 to 14-year-old children, Again, all of these have been found, but the male gender and being underweight were the most important risk factors from the ISAC study, in the multicenter study in India for 13 to 14-year-old children. If you look at the insert study, all these are important, but these are very, very small effects. The major effect has been found to the family history. We have discussed the various genetic polymorphism that could be responsible. And then the second most important one in adults was found to be smoking. Thank you very much.
Thank you, Dr. Mahesh. Very crisp and precise presentation. I think we'll keep the all question answers after the all presentations, because that will save us time and we'll keep every lecture in time. So now I request Dr. Gayatri to present her topic on allergic rhinitis and non-allergic rhinitis. Dr. Gayatri.
I'll be speaking in nutshell about allergic and non-allergic rhinitis. Allergic rhinitis is one of the most common disorder, yet commonly ignored too. 400 million people suffer from allergic rhinitis worldwide, and we have seen a steep rise in the prevalence of this allergic rhinitis in past 3 or 4 decades or so. Rhinitis is broadly classified into infectious rhinitis, allergic rhinitis, and non-allergic rhinitis. Infectious rhinitis is something to do with the viral, bacterial, etc. So we'll be concentrating on this allergic and non-allergic rhinitis today. By definition, rhinitis is defined clinically as having 2 or more symptoms of anterior or posterior rhinorrhea, sneezing, nasal blockage, or itching of nose during 2 or more consecutive days for more than 1 hour on most of the days. When these symptoms are because of an immunological sensitization of 1 or more environmental allergens, this is called as an allergic rhinitis. So allergic rhinitis, is to be more specific, is an IgE-mediated type 1 hypersensitivity. What exactly happens in an allergic rhinitis patient is when an antigen is getting exposed, the antigen is taken up by an antigen processor cell and is presented to T lymphocytes. T lymphocytes will then tell a B lymphocytes to produce these IgE antibodies. These IgE antibodies will go and sit on this mast cell, which is called as a priming. Now, with the further exposure of these allergens, this will go and sit on the mast cells or FAB end of these IgE antibodies, which is called as a coupling reaction. And with this coupling reaction, there is release of all mediators such as histamine, leukotrienes, etc. So there are early phase mediators and late phase mediators. Early phase mediators predominantly causes symptoms like a sneezing, rhinorrhea, and pruritus, and late phase symptoms are predominantly because of a tissue infiltrations, and they are responsible for nasal congestion and also for a bronchial hypersensitivity. So when we see a patient of an allergic rhinitis, if you look into a nose, you will see that their nasal mucosa is pale, and you might also see a boggy terminate and kind of a thin allergic mucin. Especially in children, you can see some maneuvers like an allergic salute, and also because of a frequent allergic salute, you can see a supra-nasal crease. There could be Denny Morgan's line because of a venous congestion, and in oral cavity, you can see granular pharyngitis. If a patient is also suffering from conjunctivitis, there could be some amount of an palpebral congestion too. Since there is a continuation of a respiratory epithelia, you can see that the disease extends to the other parts. For example, in ear as an otitis media, chronic rhinosinusitis, especially of a polyp variety, and it is not uncommon to see the patients of allergic rhinitis to suffer from either a depressive disorders, anxiety disorders, sleep-related disorders. So what I basically here mean is allergic rhinitis is not just in the nose, it is a systemic disorder, and we need to look beyond nose also. It would be unfair on my part if I don't tell about the link between allergic rhinitis and asthma, which is the highest comorbidity that we see. Nearly up to 40% of allergic rhinitis patients are suffering from an asthma, and vice versa, nearly 80% of asthmatic patients will be suffering from allergic rhinitis. So for an ENT surgeon, it would be good to ask for a symptoms of an asthma, and vice versa for a physician to look into the presence of allergic rhinitis in asthma patients. So do we require any test to diagnose allergic rhinitis? No. A typical history, family history, duration of the symptoms, seasonal variability, etc. That itself will be alone enough for us to diagnose allergic rhinitis. But some specific tests such as a skin prick allergy test may be required for a better management of our patient. So one of the tests that we do is a skin prick allergy test, where the culprit or a suspected allergens are placed on a patient's arm or a forearm, and we slightly prick it with a lancet, just an epicutaneous prick, and the test is validated by a negative control, which is saline, and a positive control, which is histamine. A wheal and flare reaction is looked for after 20 minutes, and any reaction which is more than 3 millimeters from a negative control would be considered as a positive reaction. Skin prick allergy test is regarded as a gold standard test for allergy diagnosis, and it's supported by various organizations too. What about the other tests that are commonly asked in allergic evaluation? The second test is an in vitro test or a blood test, is an expensive, less sensitive when compared to skin prick allergy test, but can be done in a situation where SPT cannot be done. Nasal cytology is generally not asked as routinely, but if you are suspecting non-allergic rhinitis with eosinophilic syndrome, then you can ask for absolute eosinophil count. Total IG are not usually a recommended test. X-ray, nose and PNS are not being useful for a diagnosis of allergic rhinitis. CT scan, nose and PNS if we are suspecting any nasal polyps, or if there are possibilities of any anatomical deformities, then we would ask for a CT scan, nose and PNS. So which are these allergens which commonly cause allergic rhinitis? 96% of the time it is aeroallergens, or what we call it as an environmental allergens, which causes allergic rhinitis, and they predominantly come from a category of house dust mite, pollen, fungal spores, animal danders, and infect epithelia. Allergic rhinitis and its impact on asthma is an international body which has actually classified allergic rhinitis into 4 groups depending on the duration of the symptoms and depending on the severity of the symptoms. Intermittent is when the symptoms are present for less than 4 days per week or for less than 4 consecutive weeks, and persistent is when both are present. Moderately severe is a disease when you have a disturbance in sleep, disturbance in quality of life, reduced productivity, etc. And mild when these symptoms are not there. So with this, we have 4 permutations and combinations of a classification. Why this is important is ARIA extend its the classification into a treatment line also and guides us there. So if it is only a mild intermittent, we will be focusing mainly on an antihistamines only. Whereas when it is mild persistent or a moderately severe intermittent, we would be introducing intranasal corticosteroids too. Whereas when the disease becomes moderately severe persistent, the main focus is on an intranasal corticosteroids. And also we also look in for, if there is no improvement, look for an anatomical deformities, ENT referrals or a specialty referrals, etc. You can see on the bottom line that the allergen and the irritant avoidance measures have to be practiced whatever the stage that you fall into. So that's why clinicians should spend sufficient time on educating on environmental control measures, and the avoidance measures that we tell to our patient has to be patient specific. Don't just give a blanket avoidance measures for every patient. A pollen allergy patient will follow a pollen allergen avoidance measures only, and so also for a fungus allergy. And the avoidance measures that we are going to tell have to be practical to that particular patient, so that that patient can sustain that practice for a long time. So these are the basket of a pharmacological agents that we have for the treatment of allergic rhinitis. On the top, we have an antihistamines, the oral antihistamines. sufficiently or effectively covers the histamine-mediated symptoms, and they start their action within 1 to 1.5 hours. First generation antihistamines are no more being used for a treatment of allergic rhinitis, and we use a second generation antihistamine such as levocetirizine, fexofenadine, bilastine, etc. Antihistamines in a nasal forms has a very quick action within 15 minutes time, and that in combination of an intranasal corticosteroids are very effective and are capable of covering all the symptoms, and this combination is supposed to be superior than using these molecules alone. Intranasal corticosteroids are the drug for the treatment of allergic rhinitis, and you can see that this effectively covers all the symptoms of allergic rhinitis. Only thing to be considered is they have some priming time of around 7 to 10 days where their maximal effect starts, and you might require a help of an antihistamines in this initial period. Nasal decongestants are very potent in reducing nasal obstruction for a short period of time and should not be used for more than 5 days time. Anticholinergic agents such as an ipratropium bromide could be of use when rhinorrhea is a predominant symptom in your patient. This table, which tells us about the different characteristics of intranasal corticosteroids that we have, the two things that you need to see is a bioavailability and a highest glucocorticoid receptors affinity. And the one which has a least bioavailability will be safer for a longer duration, and one which has a highest glucocorticoid receptor affinity will be very efficacious in their effect. A small group of patients may not benefit adequately even though they do take a pharmacotherapy and do follow allergen avoidance measures, and that group of a patient might definitely benefit from something called as an allergy and immunotherapy. Allergy and immunotherapy is the only modality of a treatment which is shown to have a disease modifying action. In allergic rhinitis, immunotherapy is advised for a more persistent disease and for a more severe variety of a disease, whereas in asthma, we would prefer to treat it for a milder disease where the airway remodeling hasn't happened much. So does this mean that all patients who are sneezing are from allergic rhinitis? Not necessarily. So we might have a small category of patients who are not IgE mediated and still have a similar symptoms. So some specific types here are a senile rhinitis, where it predominantly comes because of an older age seen above 65 years age. Predominantly rhinorrhea is a symptom there, and it is because of a neurological dysregulation. Gustatory rhinitis, where when patient develops a rhinitis here on eating a spicy food, hot food, or sometimes even alcohol. This is because of a gustatory reflex. Occupational rhinitis can be both IgE and non-IgE mediated. IgE mediated can be something that we see in a sericulture, and non-IgE mediated are because of an irritant or a chemical exposures. In some industries especially where you have an exposure of an aldehydes or isocyanates, etc., they can have a lot of irritations which are causing because of these irritants, etc. Hormonal induced rhinitis during a puberty, pregnancy, menopausal age, hypothyroid status. These are a common state where we can see a hormone induced rhinitis. Drug induced rhinitis, history taking in rhinitis is very important, especially in elderly patients. Patients who are hypertensive, who are on beta blockers and AC inhibitors, their rhinitis could be because of these drugs. Also should be asking for a history of an NSAID intake and increase in symptoms. And yes, some patients who are on OCPs also can have a drug-induced rhinitis. So overall, nearly 200 million people worldwide also suffer from a non-allergic rhinitis. Non-allergic rhinitis decreases with age in pediatric population, whereas increases with age in adult population. But however, asthma is similarly associated with both allergic and non-allergic rhinitis. So why do we get this? One is because of nose as a sensory stimulation, also from where the nerve ending it gets stimulated to cause these symptoms, and also because of an imbalance between parasympathetic and sympathetic stimulation. So in health, we have a tandem between this sympathetic and parasympathetic stimulation. But what happens in vasomotor rhinitis is there is a increased neuronal efferent traffic to blood vessels that are supplying the mucosa. And this why this stimulation can come from various other stimuli like a chemical, physical, irritants, etc. So by clinically, what are the differences between allergic and non-allergic rhinitis? Allergic rhinitis is because of a aeroallergen trigger. Non-allergic rhinitis is because of an irritant trigger. Allergic rhinitis, the symptoms are more predominantly the sneezing and pruritus, which is histamine mediated. Non-allergic rhinitis, the symptoms are more of a nasal congestion and a post-nasal drip. The nasal mucosa appears normal in non-allergic rhinitis and nasal mucosa appears pale in non-allergic rhinitis. Some specific treatment for a specific diagnosis. For senile rhinitis, ipratropium bromide could be of use. For gustatory rhinitis, avoid such triggering foods and use a nasal capsaicin. For occupational rhinitis, try not to be in such occupation which causes your symptoms. Hormonal induced rhinitis responds and all other rhinitis responds very well to nasal corticosteroids. And yes, especially pregnancy induced rhinitis also responds well to saline nasal irrigation too. It would be not right on my part if I don't add a word on lifestyle and allergic disorders. I said in the beginning that there's a steep rise in allergic disorder in the past 3 decades. Now, this cannot be only attributed to allergens. So the way we have chosen to live with, the type of the food that we are eating, the type of the air that we are breathing, all this also contributes to allergic disorders. So we have to focus on these parts too when we are treating an allergic rhinitis patient. As a whole, while treating an allergic rhinitis patient, spend enough time on educating these patients, focusing on an allergen avoidance measure, give them a good pharmacotherapy options, and also tell them about the need to use a pharmacotherapy agent persistently. And a selected group of patients will definitely benefit from immunotherapy. Thank you.
Thank you so much, Dr. Gayatri Pandit. Excellent discussion on allergic and non-allergic rhinitis. Now we start with the next session. That is next topic, that is allergic rhinitis and asthma in children by Dr. Neeraj Gupta. So over to Dr. Neeraj Gupta from Delhi.
Thank you, sir. So after the 2 deliberations, we will be talking about pediatric case-specific condition. So I will be taking you through a case. Rahul, a 9-year-old child who is 50 kg, presented to us with cough and breathing difficulty for 3 years. And the symptoms are more in the late evening and early morning hours with frequent night awakening. Mild problem happened around the year with exacerbations somewhere in September, October. And most episodes are preceded by sneezy, itchy and blocked nose. More the complaints are for past 1 year. In the past, there was some history of eczematous skin lesions in early childhood. In family, father was having history suggestive of rhinitis and younger siblings having history suggestive of asthma. Now, grandfather smokes BD, but he claims that he only smokes outdoors. And grandmother is like a very religious lady, uses incense sticks for the prayer. Rahul also has a dog for 3 years, but he says that he is asymptomatic with dog. And Rahul resides near Ashram Chowk in Delhi, which is a very busy, polluted area. On examination, as Rahul is clearly overweight, he is having allergic shyness and chest is having bilateral occasional V's, otherwise no other major findings. So the diagnosis of Rahul seems to be asthma and allergic rhinitis. You understand allergic rhinitis why? Because Dr. Gayatri has already spoken to you about that. But regarding asthma, as we understand, as per the GINA guideline, allergic asthma is considered to be like a heterogeneous disease with chronic airway inflammation. Typical symptoms of wheeze, shortness of breath, chest tightness, and cough. The important thing is that these symptoms vary over time and intensity, and there has to be a variable expiratory flow obstruction. Now, issues with Rahul are: 1, the asthma, which seems to be like perennial with seasonal exacerbation. 2nd, at the childhood, there was history of eczema, then asthma, and now developing rhinitis, so some sort of allergic march which is going on. There is a significant family history which is there. Child is obese, and then there are certain triggers or a potential trigger like a dog dander, third-hand smoke, or outdoor pollution. Now the question is that why we are talking about a pediatric case or why it is different from adult. So what we need to understand that the fundamental difference in the airway or the trachea of a child versus an adult. So a child who is having a smaller airway versus an adult who is having a relatively larger airway. Now, an equivalent amount of edema or inflammatory edema will cause like a approximately 2 millimeter constriction in the, this is an example, approximately 2 millimeter constriction in the child airway, whereas the same constriction in the adult airway. But the actual difference, the cross-sectional area will be reduced markedly in the child as compared to adult, and the resistance, which is actually considered to be the inverse power of quarter power of 4, so which will be raised 16 times as compared to adult. So the same amount of inflammatory edema in the airway, but the child will be having more increase in the resistance, manifold increase in the resistance of the airway, and he will be more symptomatic as compared to any adult. So how to diagnose? Usually history is sufficient, but we need to demonstrate the expiratory airflow obstruction and reversibility. And as GINA guideline also says, spirometry is required. So we all understand that for spirometry, we need to see this flow volume loop in which the expiration and the inspiration, in the normal condition, it happens like this. And then in the volume time curve and the flow time curve, flow volume curve, these are the normal curves which happens. But what happens in airway obstruction, especially in case of reversible airflow obstruction or asthma, that this FEV1 drops. That means the forced expiratory volume in 1 second drops. And similarly, here in the flow volume loop, the peak reduces, and then there is some scooping which happens in the expiratory limb, which is important. Now, this is Rahul's spirometry, which also says that as compared to the normal expected, the peak is much lesser, and then there is a scooping, and then giving the post-bronchodilator means the post-bronchodilator, there is a significant reversibility, and the peak is actually reversed a little bit, and scooping has also become better. We all understand the interpretation of PFT, not going in detail. The important thing is that as compared to adult, where the FEV1 by FVC ratio is considered to be 80 or 85% as the lower limit of normal, and the pediatric age group, it is considered to be 90%, so which is another significant difference in pediatric age group. Now, how to manage this child, Rahul, which we consider. So this is the pediatric algorithm from 6 to 11-year-old child with a diagnosis of asthma, which is like a stage-wise approach in which Rahul's symptoms are matching somewhere like symptoms which are mostly daily, and they are like early morning, and they are like also getting, you can say, like a seasonal exhibition. So he is falling somewhere in between step 3 to step 4, and we need to start him on some medium dose inhaled corticosteroid along with LABA, or a low dose ICS formoterol maintenance combination. So, and these are the doses which are considered to be here. So what we did is that we chose budesonide at 600 microgram per day. So Rahul treatment plan was like a budesonide dose of 600 microgram per day with a fixed combination of formoterol. We started, and appropriate technique was explained. And at 3 months follow-up, still symptoms are poorly controlled, and there was still frequent need of SABA was present. So these are the 4 criteria as per the GINA guideline for pediatric age group, which are qualifying for the control of the patient during the follow-up, in which we see that how frequently the asthma symptoms are still coming, or whether there is any nighttime awakening is there, activity limitation is there, or SABA requirement is there. And depending upon that, it is classified as either well-controlled, partly controlled, uncontrolled. And the potential causes of not a good control could be the incorrect diagnosis. So each and every time we have to revisit the diagnosis. Asthma mimics, which are important, specific for the pediatric age group. Incorrect technique, which we need to take in cognizance each and every visit, inadequate doses, and then comorbidities. So here the 8 specific conditions which could be the asthma mimickers in this particular condition. One is chronic upper airway cough syndrome. Another is the foreign body. So foreign body is an important differential in the pediatric age group, so which one need to consider. And then there are certain other conditions like congenital heart disease, bronchopulmonary dysplasia, and even cystic fibrosis is also possible in this particular age group. And in adolescent age group, we sometimes find bronchiectasis also as an important differential. So in this particular child, Rahul, the diagnosis was rechecked. There was no other alternative diagnosis which we were able to get. Inhaler technique was also checked, and it was acceptable. ICS dose was increased, and then we understood that the comorbidity in the form of allergic rhinitis, as Dr. Gayatri spoke, inhaled nasal steroids were added, and later on montelukast as an add-on drug was also added as per the GINA guideline, where you can add on, you can say like leukotriene receptor antagonist if the patient is not responding. And here, this child is now classifying in the category of difficult to control asthma. So what is difficult to control asthma? That means if a child who is still having an uncontrolled and partly controlled symptom on medium or high dose of ICS, or those who actually require higher dose of ICS and you cannot wean it down to maintain the good symptom control, these are called as difficult to treat asthma. Now, this difficult to treat asthma is actually an umbrella term, and under this umbrella term, it could be because of the inappropriate technique or inappropriate doses, or it could be because of the real severe asthma, which is like uncontrolled condition despite the good adherence and inhaler technique. So what should we look for now in this child? We need to really go for the phenotypic differentiation. That is the type of inflammation. I'm not going in detail as there is a separate talk on phenotypes of asthma, but we need to really see that which type of phenotype the child is belonging to. We need to see the triggers and then the comorbidities. So the triggers could be in this particular child dog. So as the child is having dog for past 3 years, so the child claims that there are no symptoms, but he is actually having a vested interest that if he says the dog is creating problem, the dog might be taken away. So we need to really see that whether the dog is problematic. Seasonal change is there. September, October is the season. So we need to see which allergen is really creating the problem. And then the environment. Dr. Mahesh has already spoken about pollutants and a third hand smoke, which is happening through grandfather. And then there is some incense stick burning, which is also happening. Investigations in this child, allergen testing, total IG, usually having not much role in allergy testing or allergy diagnosis. Then serum specific IG or skin prick test can be done, and environmental history. So in this particular child, the specific IG for milk was just borderline positive, wheat was just borderline positive, not matching with the history, whereas the skin prick test was positive for the house dust mite, clearly evident 8 into 9 millimeter, and cockroach 6 into 6 millimeter. Possibly, cockroach might be responsible for the perennial complaints, and house dust mite might be aggravating like a September, October seasonal complaints in this child. Regarding the smoking and asthma, so I am talking about the pediatric age group mainly, so which is like mostly second-hand smoke or a third-hand smoke. So if the mother is smoking during pregnancy, then the odds of getting asthma or developing asthma in child is somewhere around 1.8. But another important thing is that if one generation earlier, like grandmother has smoked during pregnancy, and even if mother has been asymptomatic, still the odds of increased asthma risk are 2.6 in the grandchildren. This is because of the epigenetic changes, which is very important and very alarming. And that is why GINA reiterates that we have to really ask them to stop maternal smoking during pregnancy and avoid exposure to tobacco smoke in infancy. So the advice to Rahul for environmental control will be, as per the GINA guidelines, the cessation of smoking and environmental tobacco smoke, and the smoking has to be stopped at all the level, whether it could be the antenatal, whether it could be the second-hand smoke or the third-hand smoke or the first-hand smoke. All levels of smoke have to be stopped. And weight reduction, which is also an important factor, especially in case of Rahul, because obesity is like pollutant itself, like obesogens, or obesity increases that reduces the functional residual capacity of lungs, and ultimately it really becomes difficult to get an optimal control of asthma if you do not ask them to reduce weight. This is important. Pollution and respiratory allergies, already spoken well. Allergic rhinitis and asthma have been seen that as the pollutant score increases, allergic rhinitis and asthma increases. Certain different factors as per the literature. Pollution affects allergies by various methods. So one is like they increases the pollen count, then by increasing the pollination season, then they increases the pollen fragility. So the pollen breaks easily, and ultimately the small molecules inside the pollen liberates easily. Pollen protein content increases. Pollen allergenicity increases because of the nitrosification and sulfur dioxide reactions. And then certain adjuvant effects like increased IG, eosinophils, and neosensitization happen. Pollutants also cause direct injury to mucous membrane and ultimately causes direct bronchoconstrictor effect and also causes altered microbiota. So pollutant, it is not only one thing. It is like a many different type of ways it actually affects allergies. What can be done for allergens? Like we spoke about dust mite. So these are the guidelines as per GINA. So dust mite is like certain encasings which are available, which can be done. The best thing is that you can ask them to wash the beddings in a temperature more than 55 degrees Celsius and then ask them to sun dry. Another important thing is the good ventilation in the room, which is important. And then you need to really ask them to use vacuum cleaners with a HEPA filter, which is important. And air purifiers are not going to benefit. Similarly, for the pets, it's a HEPA filter vacuum cleaner, which will be useful. But the ideal technique should be that the pet should be removed from the surrounding. That is the best thing. And then cockroaches. So the professional extermination of cockroaches, which is important. But not only a single intervention is going to help here. It is the multimodal approach. So we need to tell them many different interventions simultaneously, and that will be more helpful rather than one single intervention for any of these things. Now, mom wants to ask about the permanent cure to halt the allergic march. And as has been spoken earlier, allergy and immunotherapy is the only answer for the permanent cure to halt the allergic march, which actually changes the Th2 milieu, the atopic milieu, to Th1 milieu or the non-atopic milieu. And the choice of immunotherapy that can be chosen patient to patient as the subcutaneous route, though it is a little more efficacious, but the safety is a little bit concerned, whereas the sublingual seems to be more safer, more acceptable, especially in the pediatric age group, but a little bit less efficacy. So patient is really in equipoise. Mom is now satisfied with your answer, and now she wants to bring the Rahul's younger brother, which is Sunny, 4-year-old, who is also having recurrent wheeze since early childhood. Each episode lasts for almost 2 weeks and documented milk allergy in infancy. Now, mom wants to know that is Sunny is also going to suffer from asthma as Rahul. It's an important question. He is now only 4-year-old. So can we answer this? Yes. So probability of asthma diagnosis in children 5 years and younger, it is like if a child who is having symptoms which are occasional, the symptoms are lasting lesser, that means less than 10 days or 2 to 3 episodes per year. Otherwise, asymptomatic in between episodes, there are very less likely chances that this child will be having asthma. On the other hand, like case of Sunny, who is having like symptoms more than 10 days, almost 2 weeks symptoms, more than 3 episodes per year, if the symptoms are happening in between episodes also, and then there is some allergic sensitization which is documented, food allergy, like in this case, milk allergy has already been diagnosed. So there are chances, other family history, strong family history is there. So it is likely that this child, Sunny, is likely to continue with the asthma type of episodes later on. Important thing, common differential diagnosis less than 5 years, apart from the common foreign body and others, which we spoke about. The other thing is gastroesophageal reflux, which is important in children. Then certain congenital anomalies like tracheomalacia, which is important. Tuberculosis is a very important differential. And nowadays, apart from the increase in asthma prevalence post-COVID, even we have seen the tuberculosis cases have also increased. And then certain other conditions like vascular rings, they can also be found. And then we should not miss immunodeficiency. Mom is worried that he cannot perform spirometry. He's too young. He's 4-year-old. Can you do something else to see the lung functions? So yes, there is another modality which can be used in pediatric age group, which is called as oscillometry, which works on the basis of sound wave. What it does is that whenever the patient is breathing through the respiratory flow, then at that time, this loudspeaker is producing certain sound waves which are going inside the lung, coming back, received by the transducers. Ultimately, they are able to detect the resistance and the reactance. And based upon that, they will tell us actually the small airway obstruction, large airway obstruction, or restrictive lung disease. The next question from mom is Sunny is also going to continue with asthma? I've already answered. And how you will treat. So this is the term which is called as modified asthma predictive index. So children which are having more than 4 wheezing episodes per year during the first 3 years of life, and if they are satisfying with at least 1 major criteria or 2 minor criteria, they are likely to continue asthma more likely. So this is called as a positive modified asthma predictive index. The major criteria are parents with a diagnosis of asthma, physician diagnosed atopic dermatitis in the child, which is there in this one, and sensitization to 1 or more aeroallergen. Whereas the minor criteria could be blood eosinophilia, sensitization to food allergen, and wheezing unrelated to food. And the differentiating feature in between childhood asthma and adult asthma, already spoken about a lot, but it is like the males which are more suffering in the pediatric age group, the remission is more chances are there. But once the asthma is reached to adulthood, the chances of remission are less. The another important thing is that factors which are associated with severity, it will all depend upon asthma duration. We already spoke about that. Medication use, lung functions, phenotypic differentiation, and then also the socioeconomic status. So these are like the different type of phenotypes in the pediatric age group, which could be like the frequent wheezer, recurrent wheezer, multi-trigger wheezer, episodic wheezer, and then the eosinophilic, neutrophilic, and many other. Whereas in adult, it is mainly related to the comorbidities. It could be the late onset eosinophilic asthma, obesity related, aspirin associated, or ABP type of thing. So children 5 years and younger, the algorithm, there is no stage 5 or step 5. It is only 4 stages, step 1, 2, 3, 4, which are there. And there is also a term which is called as the primary prevention of asthma. Like children should not be exposed to environmental tobacco smoke, already spoken about that, during pregnancy or after birth. Then identification and correction of vitamin D insufficiency in women, which is also important. Vaginal delivery and breastfeeding, they need to be promoted. And use of broad spectrum antibiotics need to be curtailed, especially in infancy. So the last slide, take home points. Childhood asthma is different from adults. It is time to think beyond inhalers. We need to really think about the preventive aspects. We need to really think about the phenotypic differentiation, differentials of that particular asthma, especially in an atypical presentation. Allergy and immunotherapy is the only cure or only disease-modifying available therapy right now present, and we need to think about prevention at all the stages. With this, I will stop my presentation. Thank you.
Thank you, Dr. Neeraj Gupta. Very well said. Now, our fourth topic comes from Dr. Professor DJ Christopher. allergic rhinitis and bronchial asthma in adult population. Over to Dr. Christopher.
Thank you, Dr. Jaffrey.
Thank you.
Since Dr. Gayatri has covered allergic rhinitis extensively, and in a session like this, there is bound to be a lot of overlaps. So what I did was I cut off a lot of slides which had to do with allergic testing, desensitization, and I essentially confined my talk to the evolution of treatment of adults with asthma, which I think is really the area in which most development has happened in the recent times. And of course, the GINA guidelines, you may know, the last one actually has taken a substantial leap in terms of how we manage asthma. So I'm going to start with the evolution of treatment to take you through how things occurred over the years. So GINA 2020 defines asthma as the most common chronic communicable disease affecting a large number of people. And asthma is characterized by variable respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough, and variable expiratory airflow limitation. It is usually associated with airway inflammation. And asthma is characterized by worsening of symptoms, and these are called exacerbations or flare-ups. They can even be fatal. Thankfully, fatality has come down substantially with the good treatment that we today have. And again, very important to take home is most of the mortality and morbidity associated with asthma is preventable, particularly with the use of inhaled corticosteroids. So these are foundational principles, and we need to remind ourselves of this. So I just want to reiterate an important concept with a simple illustration. Most of us know this plant. This is called Touch Me Not. And as children, we may have all played with this plant. So what it does is, you touch many plants, nothing happens to the plant. But when you touch this plant, it shrivels up. So this is a way of understanding airway hyperresponsiveness. So once inflammation is established in the airways, several allergic or irritant stimuli will cause this response in the airways. Of course, in the airways, it looks like this. It is very thick. The muscles are constricted. That's what you see here. And then you also see probably secretions within the airway, some of them quite thick. And all of these contribute to airway obstruction. Now, just a quick illustration, taking this basic information forward to treatment. So the asthmatic airway is like this, a combination of constriction. These lines you see are muscular constriction and also in airway inflammation, which is characterized by edema. So both these contribute to a very tight airway. Now, when we treated asthma with bronchodilators, not very long, maybe 2 decades before, most of the treatment was bronchodilator centered. And this is what it did. It gave immediate relief of symptom, but did not take care of inflammation. And anti-inflammatory drugs actually changed things dramatically, and there was both bronchodilation in the immediate context and also more sustained because of relief of airway inflammation as well. Of course, as has been reiterated, lung function tests should be done for all asthma patients. And what is characteristic is post-bronchodilator improvement in FEV1, which GINA stipulates should be more than 12% and also more than 200 ml. Not and, but and. Both should be fulfilled to to fulfill criteria for asthma. Pheno is the other test that is being popularly used, and since this has been dealt with in a previous lecture, so pheno of less than 25 parts per minute is used to indicate that eosinophilic inflammation and responsiveness to steroids is less likely. So in other words, these people may not be benefit from inhaled steroids at that point in time. Now we have to understand that asthmatic inflammation is a dynamic factor. And if pheno of more than 50 parts per billion is used to indicate eosinophilic inflammation in symptomatic patients, which is responsive to corticosteroids, and therefore will indicate a patient needs to be put on corticosteroids. Values between 25 to 50 should be interpreted with caution and based on the clinical background. Allergy testing has already been talked about, and this is something that you will do if you have two goals in mind. One is to identify specific allergens and advise patients to avoid them and guide them with allergen avoidance. And also if you contemplate doing desensitization. It is not just done without any aim or goal, but with a specific purpose. And again, we do not test 50 or 100 or 200 allergens as is frequently done. You come up with a compact set of allergens which give you meaningful clinical use and which you can help to advise patients. I just want to introduce a concept of minimal persistent inflammation. Now, many patients come and say, I took the inhalers, 1 week later, I was perfectly all right, I stopped it. Now, we have to understand that, in this diagram, you see triggers, and these red bars are inflammation. Okay, so trigger. So what happens? This patient has had a trigger, and at this point, the patient starts developing inflammation. But the inflammation is not severe enough to breach the threshold for symptoms. The patient is still asymptomatic. And then triggers here, this has breached the threshold and the patient is symptomatic. And this hasn't breached, this has breached. So patient is now symptomatic. Now, was there no inflammation at this point? There was inflammation, but the trigger was not sufficient to breach the symptomatology. So patients should be communicated this concept that even though they do not have symptoms, inflammation may still be present, and that lays the basis for relatively protracted treatment that we give for asthma patients, even beyond their symptoms. And cautiously we step down, and when possible, we stop the treatments. Okay. So it is very well established decades ago that corticosteroids are the most effective anti-inflammatory medication, completely revolutionized the care for asthma and the quality of life of asthmatics. Then came long-acting beta-2 agonists, salmeterol and formoterol, and then we realized that a combination of LABA and ICS works synergistically and is better than giving inhaled corticosteroids alone. And today we hardly ever treat patients with inhaled corticosteroids alone. We give them together. What is the basis for this? We thought initially, those of us who practiced medicine respiratory medicine at that time and treated asthma will know, we thought that corticosteroids are anti-inflammatory, but they have no role in beta-2 receptors. And we said beta-2 receptors are bronchodilators and they have no role in corticosteroid receptors. But with LABA, this concept was questioned, and we know that corticosteroids act in corticosteroid receptors, and they also act in beta-2 receptors and increase their number. So if more beta-2 receptors are available, they there are more targets for LABAs to act, and that's how they act synergistically. Conversely, beta 2 receptors, which normally act, LABAs which act on beta 2 receptors, also have a potentiating effect in corticosteroid receptors. So all in all, the benefit of combining these two is more than the sum of the effect of these two drugs. So this is now what we use, and this is the basis of this, and we have known this for about 1.5 to 2 decades. And of course, LABA and ICS provide overall control of asthma and are the gold standard of treatment. Okay, what is the next step in the evolution of treatment of asthma? The next step followed trials on what is called the SMART strategy, which is single maintenance and reliever therapy. What is that? Budesonide and formoterol is arguably the best LABA-ICS combination. Why is that? Why not salmeterol and fluticasone? The reason is that formoterol is a short-acting drug, and it acts as quickly as salbutamol. Therefore, it has the advantage of also being used as a reliever. You can use formoterol instead of salbutamol with the same efficacy, of course, with a longer duration of bronchodilation. So, combining budesonide and formoterol initially was used on as a controller combination with twice daily used. But studies that used a SMART strategy, this particular study that used 160 micrograms, 2 puffs twice a day, plus terbutaline as needed. So LABA-ICS plus terbutaline as needed. And another group of patients were given budesonide formoterol, 2 puffs twice a day, same dose, with additional inhalations of budesonide formoterol as needed. So here, twice daily LABA-ICS plus LABA-ICS as required. So what happened? The primary outcome of this study was the first severe exacerbation. And this is what they found out. So this is the budesonide formoterol with budesonide formoterol itself as reliever, and this is budesonide formoterol with salbutamol or terbutaline actually in this study as reliever. So what they found was that the exacerbations are significantly less when budesonide formoterol was also used as a reliever in addition to being a preventer. The ER visits and hospitalizations were significantly less. Systemic corticosteroids were significantly less, and the peak expiratory flow fall was also significantly less. So every clinical endpoint was significantly better when we used budesonide formoterol on a twice daily basis and also as a reliever. Okay, now you may argue that, okay, they may have used more number of inhalers in the budesonide formoterol reliever group. And they would have definitely used more ICS because that is also present in the reliever. And that was the reason why this group did better. Actually, they found that the number of inhalers were actually less with the budesonide formoterol. They took less inhalers. They also used less inhaled corticosteroids than the group that used regular twice daily budesonide formoterol. So this study concluded that with as required budesonide formoterol compared to regular budesonide formoterol and using SABA as a reliever, there were reduced exacerbations, improved symptom control, less systemic corticosteroid use, improved lung function, less rescue inhaler use, and less inhaled corticosteroids use. Every outcome parameter was better when the SMART strategy was used. And that was the strategy, and that continues to be the strategy that we follow today. Now, I just want to take you through the landmark changes in asthma management that occurred with GINA in the most recent guidelines. So the change is that GINA, which used to recommend SABA for step 1 when patients had intermittent symptoms, now recommends low-dose ICS LABA instead of SABA. So SABA-only treatments increase the risk of exacerbations, and adding ICS reduces the risk. So GINA now recommends that all adults and adolescents should receive ICS-containing controller treatment even in stage 1. Okay, now why? What is the reason? And then they actually look at this as a population level risk reduction strategy. So if you see in the cardiology spectrum, why do they treat hypertension aggressively? Because they want to reduce myocardial infarctions and strokes. Why do they use statins? They want to reduce coronary artery disease. So it is a population level strategy. So it is believed that this was a similar strategy. By using ICS LABA as reliever, overall you will reduce the serious asthma, serious outcomes at a population level. Now, this is the, So this is the new strategy. They have actually bifurcated the steps, unlike before. And the preferred model is what we said. ICS LABA will be the reliever here in steps 1 and step 2 and step 3 and step 4 and step 5. So all through ICS LABA, low dose ICS LABA will remain the reliever. But as before, in step 1 there's only as required, and in step 2 ICS low dose ICS LABA is used BD. Then in step 3 low dose ICS LABA. In step 4 medium dose, and in step 5 high dose. And then of course you have the scope of adding anti-IG and other biologics, and higher dose of ICS LABA, and all the other things. So we will look at this, the treatments for step 5 in my subsequent slide. They also retain the previous option. You can use beta-2 agonist as reliever and take in step 1 ICS whenever SABA is taken. So since the concept that ICS should be taken has come, if you use this as a reliever, you should also use ICS alone in step 1. In step 2, of course, also there is low dose maintenance, and of course you use this as a reliever, then progressively low dose, medium dose, and then high dose. So this is a step care therapy as we have with the latest GINA. Sorry. Okay, now what is the reason for this change? So this rationale is very important to understand. There is no evidence that SABA used alone is safe or efficacious. No, but we have used it for decades. Yes, we have used it, but actually there is no evidence that this strategy is an effective strategy for the following reasons. Patients, even with infrequent symptoms, can still have underlying inflammation, therefore severe or fatal exacerbations. Of course, these are triggered by viral infections, allergen exposure, pollen exposure, and so on. And even occasional use of OCS or oral corticosteroids increases the risk of serious adverse outcomes. So starting SABA alone trains the patient to regard this as primary treatment. This we know, patients just keep on taking SABAs because that's the first drug they use, and it gets ingrained in their mind that that is the base treatment. and therefore they will continue to take it even when they develop more severe disease, and therefore they will overuse it. And the goal of treatment is not just symptom control. SABA gives only symptom control but doesn't do anything to risk reduction. That is why this combination is important. And of course, this is required across all asthma severity spectrum. That is why this is a reliever across all severity spectrum. And of course, there are multiple, I think at least 4 studies that endorse the use of ICS-LABA as a reliever. There's no time to look at it. So let's now move to severe asthma, which again is the area of much interest today. Before going to that, we need to look at some terminologies. What is uncontrolled asthma? This is frequent symptoms and or exacerbations. Many of these patients may even have mild asthma. So they need not even have moderate or severe asthma. Now, they can easily be controlled. Uncontrolled asthma in these people can be often well controlled. Now, difficult to treat asthma or asthma uncontrolled in spite of high dose preventer treatment. Here you have scope to increase dose and control them, but here you're kind of reaching the peak. However, they could have incorrect diagnosis, incorrect inhaler technique, poor adherence, and comorbidities. So at this point, as physicians treating asthma, we have to look at all these factors and correct all of them. Then we come to what? Severe asthma. So these are patients who have uncontrolled asthma, which we saw before, but alternate diagnosis has been excluded. Comorbidities have been treated. What are the comorbidities? Gastroesophageal reflux disease, concomitant allergic rhinitis. All these have been taken care of. Trigger factors have been removed, and adherence to treatment has been verified. So all the things that could potentially be reversed has been reversed, and the patient is still requiring high dose ICS-LABA and or use a systemic corticosteroids to keep the disease under control. So these are patients who are severe asthma. So what is the quantum of these patients? We shouldn't think every patient who comes with difficult to treat asthma or severe asthma. So about 24% of patients have high intensity treatment. So which means they are on high dose ICS-LABA, but they are well controlled. So these are not people we would worry about. 17% are difficult to treat. They are on high intensity treatment, but have poor symptom control. You have to do something more than what they are now taking. And these are the patients you would evaluate comorbidities and all other factors you can possibly reverse. Now, only 3.7% will continue to have difficult to treat asthma, and therefore will merit the branding of severe asthma, because they're, in addition to high intensity treatment, their symptom, they still have poor symptom control. And even though they have good adherence and inhaler techniques, even though their comorbidities have been addressed. Okay, now what does GINA mandate for step 5? So the options are, one of the options is adding LAMA. Now LAMA is cheap, affordable treatment, which all of us obviously use quite a bit, and we should use. Now we have to understand the limitations of this also. So there are now, before that, there are now triple drug combinations. Now these are licensed for those above 18 years. You have not just LAMA, you have LAMA, LABA, and corticosteroids. this combination with beclomethasone, then fluticasone, vilantrol, imiquimodium, mometasone, indacaterol, glycopyrronium. Depending on the pharma, these are the combinations available. So they also can be tried. Now, adding lung function to medium dose or high dose ICS LABA modestly improves lung function, but the patient's perception of symptom may not improve. This is something we have to keep in mind. So if symptoms are bothering them, you have to think beyond just adding LAMA. Then what is the impact on exacerbations? In some studies, addition of LAMA modestly increase the time to severe exacerbations, but it doesn't dramatically reduce severe exacerbations. So when patients come with exacerbations, it is important to ensure that the patients receive sufficient ICS. So if they are on low dose or medium dose ICS LABA, reliance on LAMA is not the answer, but you have to give the highest dose of ICS that they can possibly have safely. Okay, so this is how we safely use LAMA. And then I want to just quickly glance through the phenotypes, which has already been touched to a certain extent, because this is crucial for us to use biologics, which is the new kid on the block, and all of us are watching it very carefully. And we know the inflammation, allergic inflammation takes these pathways. We know that T lymphocyte is probably the king that drives inflammation. And we have the severe allergic phenotype, where interleukins stimulate B cell to produce IgE, which acts on the mast cell. So this is a IgE high or IgE rich pathway. On the other hand, the Th2 cells can drive through interleukins eosinophil production and eosinophil activity. And this we can call severe eosinophilic phenotype. And then we have interleukin 23 driven inflammation, which is severe asthma with physiologic impairment. Here the predominant factor is the muscle activity, the bronchial muscular hyperactivity. Now, this may not particularly be amenable to anti-inflammatory drugs as much as the previous two phenotypes. LAMA-LABA will work for sure, and if they are uncontrolled with all these things and are at step 5, then bronchial thermoplasty may be an option for these patients. And then we have the neutrophilic phenotype, which is probably the most difficult phenotype to treat. And in them, apart from bronchodilation and other things, you may use macrolides and other such options. So these are the phenotypes that are amenable to biologics, and this phenotype is amenable to omalizumab and the IL-5 and IL-4 blockers and all that, and the IL-4, 13 blockers, all are the ones that will benefit this phenotype. So before we use biologics, we should quickly look at what are the biomarkers that we use to phenotype. Of course, blood eosinophils are the most practical and the most widely used. For practical reasons, I think the reliance on this is justified. Now, sputum eosinophils is probably the best. The reason why it is not used is it is extremely labor intensive. Now, pheno, we have talked about skin prick testing, IgE. So these are all the biomarkers that we could use to phenotype patients. And these are the cutoffs. So now I told you that the sputum eosinophils are the best, but very difficult to do. So time consuming, labor intensive, I already covered that, but blood eosinophils are commonly used and routinely available, and we do it routinely, although not as good, but still it is the basis for us to use biologics. And it is the biomarker for eosinophilic inflammation. So what do we have for the IgE driven inflammation. Omalizumab is a drug, so I'm not going to go through the dosing. We today have mepolizumab and benralizumab. I'm not aware of anything else in the market at the moment. These work against IL-5 driven inflammation, and they are effective. I do not want to talk about relative. Probably we do not have head-to-head comparison of what is better, but both probably are equally effective in their own ways. So this is something that we have available today, and that is new, and some of us can consider using it for carefully selected patients with severe asthma. With that, I close my lecture. Thank you very much.
Dasgupta. So over to Dr. Dasgupta for phenotyping in allergic rhinitis and bronchial asthma. Our next topic is on phenotyping. Dr. Dasgupta. Hello. Dr. Dasgupta.
Good evening,
Please
everyone.
unmute yourself.
I thank
Yes.
the organizers at the outset for considering me to talk on this topic, asthma phenotypes, something which I have been associated with for the past 10 years. To make things simple, I would be talking about what is phenotyping and endotyping at first, how to phenotype and endotype severe asthma, which is very important given the concept of personalized medicine. I would discuss the different phenoendotypes of airway inflammation, and all this I would like to do by the way of presenting cases so that we can know how to translate this information into our clinical practice. Now, this is the transition from the genes to the patient. So, when we do a gene study, it's called genomics. When we do a gene expression study, it's transcriptomics. If we do a protein study, it's proteomics. And if we do a metabolomic study, it's metabolomics. And of course, the phenotyping. So we can see that there are lots of ways in which we could do these studies, but today we shall be talking about only the patient or the phenotyping of patients. Like I said, there could be several types of phenotyping that we could have for asthma or any of the other airway diseases, but we will stick to doing clinically relevant phenotyping because this is what we can actually practice in our clinics. It has been defined as being able to determine the clinical outcomes and also characterize patients with different or selective response to specific treatments, and of course, doing them prospectively. So what I'll be discussing today is completely clinical, and I will be leaving out those methods of phenotyping which do not have a clinical background. This is quite well known to all of us clinicians who do practice asthma. This is stepwise treatment of asthma as proposed by the GINA or the Global Initiative of Asthma. So why are we so bothered about phenotyping? It's because 20% of asthmatics do not respond to the guideline-based therapy, and this is the phenotype which is going to use up majority of the healthcare expenses of any country. So this is the concept of traditional medicine and how we stratify that into clusters. Traditional medicine is what GINA has taught us, treating patients considering all patients are similar, but which is not so. We can divide the patients based on certain clinical parameters into separate clusters, which is known as stratification medicine. Now, cluster analysis has been there in vogue for a long time now. This is the UK clusters, which has shown that you could have clusters which could be quite discordant amongst themselves. You could have patients with a lot of symptoms but no inflammation, or you could have a patient with a lot of inflammation and no symptoms and everything else in between as well. This cluster is what has been proposed by the ATS, or the American Thoracic Society, where they have used the FEV1s, baseline FEV1 and the maximum FEV1 in conjunction with the age of onset to define 5 important clusters. If you look at this, which is an outcome of the cluster analysis of the ATS, there is a lot of overlap between these 5 clusters. So when there is an overlap, it's very difficult to know which one is the predominant cluster that the patient belongs to, and then take on from there. So we did our own cluster analysis in Eastern India. We used 100 severe asthmatic patients, and we considered only those variables which were clinic friendly. Like serum IgE, we would do that all the time in the clinic. Absolute blood eosinophil counts, again, we do that all the time in the clinic. Age of onset and baseline FEV1 in spirometry. We used a 2-step approach, which was an hierarchical cluster analysis method. And this helped us understand how many clusters we're looking at. And then this was followed by a k-means cluster analysis to show how the clusters were distributed. There you see 4 distinct clusters when we did an hierarchical clustering. Similarly, very little overlap between the clusters when we did a k-means cluster analysis. There were 4 important clusters with 100 patients. Cluster 1 had 23% patients, cluster 2 had 35, 3 16, and the 4 had 26%. When we examined the clusters and tried to find out what was actually driving the difference in the patients, we found that age of onset was a very important parameter, whereas body mass index was not. The inflammatory and atopic characteristics were quite important. From the left-hand panel, we can see that cluster 1 and 3 were high on the absolute eosinophil counts, whereas cluster 4 had very poor or a very low count. Same with IgE. So we found that there were 4 important clusters in our analysis. Cluster 1 was early onset disease, which was eosinophilic, atopic, non-smoker patients with sinus disease. Cluster 2 was late onset eosinophilic, non-atopic patients, low baseline FEV1, and these patients were all smokers. So chance of an asthma COPD overlap was present, no doubt. Cluster 3 consisted of patients with early onset intense eosinophilia, atopic with sinus disease. They had the lowest lung function, and they had a history of allergy and family history of asthma. Cluster 4, the late onset disease, mildly atopic patients were non-eosinophilic. So this was our cluster. And let's see what we can do with an individual patient when we could cluster analyze them. So this is a 60-year-old female patient. The symptoms started at 45 years of age. The patient was an ex-smoker, atopic, was on very high dose of salmeterol and fluticasone tiotropium as indicated by the GINA. FEV1 went by FVC post-bronchodilator was 1.3 and 2.2, which is quite low. 50% FEV1, and we will have to remember that number because that's what we are going to need when we put the patient in the algorithm of the ATS. Radiology normal, echo only mild pH, but the patient continued to be symptomatic on minimal exertion. Compliance was good, no ongoing allergen exposure, and the patient did not have any comorbidities. So 50% is the number that we are looking for, which is less than 6.8%. The maximum FEV1 was less than 65%, and indeed the patient belonged to cluster 5. Now, what the drawbacks of clusters are that it's a cross-sectional a cross-sectional analysis, and more importantly, because the patients do not stay in the same cluster throughout their disease life. Patients may migrate across clusters, showing a lot of longitudinal lability, which means that every time we see a patient, we have to do all the tests and to decide in which cluster this patient actually belongs to. But all good is, this comes to an end because cluster analysis does not help us taking treatment decisions. So cluster 5 patients were severe asthma with fixed airflow, but again, what treatment do we offer our patients? This brings us to the concept of having personalized medicine. We can see that traditional medicine had uniform or considered all asthmatics to be homogeneous. Stratification is when we cut out those entire cluster into smaller ones, and then we move on to the personalized medicine so that we see patients as an individual and not belonging to any clusters with other patients. This brings us to the concept of the mechanisms that drive asthma, which are mainly of two important types, that is stage 2 type inflammation and non-stage 2 type inflammation. And further on, we could have a neutrophilic, eosinophilic, allergic, or postgranulocytic inflammation of the airways, which we are going to discuss in detail a little bit later. What are the biomarkers which are going to help us identify the underlying mechanism of the patient? They could be eosinophils in the blood. They could be eosinophils in the sputum. Serum mediators like periostin, which is not available to us in the commercial market, total IgE, allergen-specific IgE, exhaled breath, that is nitric oxide and volatile organic compounds measurement. So now, blood parameters are much easier to measure because we can do that in our day-to-day practice. Blood eosinophil count of more than or equal to 300 can predict response to steroids or monoclonals, whereas a raised IgE is an important biomarker which points at the anti-IgE or omalizumab being of response to the patient. Allergen-specific IgE predicts the response to specific immunotherapy, and like I said, periostin levels can predict and responsiveness to anti-IL-13, but again, it's not available for everyday practice. The way I remember our patients, the way I approach my patients of asthma is by trying to find out what the mechanistic point of view in these patients would be like. So three important ones that we have discussed is a B cell mechanism, a Th1, a neutrophil driven mechanism, a Th2 or eosinophil driven mechanism. Unfortunately, all these have overlapping values, so that to identify a patient with a very, very clear-cut watershed around it is very difficult. It is up to us to understand which is the most predominant phenotype or endotype. So in our patients, the blood eosinophil count was 210, which is low. Total IgE 220, which is again not that high as we would expect. Pheno is only 27. And what we have not used is the sputum biomarkers. Now, the importance of sputum biomarkers is that sputum is the secretion of the organ in discussion or the organ of interest. We would never do a blood cholesterol level to find out what the blood pressure of a patient is. Similarly, we would not try and guess what the sputum cellular count is by doing a serum IgE or, for that matter, a blood eosinophil count. Now, this is the person who conceptualized sputum quantitative assay or analysis of the cellular counts of sputum. This process is very important and has been well described in literature for a long time now. It's been almost 15, 20 years, I think. So what we do is we take sputum in a petri dish, which could be a spontaneous sample or an induced sputum sample. We look through the inverted microscope to separate out the portions of the sputum which are heavily laden with inflammatory cells and those which are not. We add sputalysine, which breaks up the mucus bond and releases the inflammatory cells. We filter this through a nylon mesh and divide it into two parts. The first part we mix with trypan blue goes into the hemocytometer and we get to do a total cell count. The rest of the sample that we had filtered through the nylon mesh goes into the cytocentrifuge, which makes a mononuclear cells, monolayer cells, and we could do a differential count on 400 cells to get a total cell count and a differential cell count, much like what we would get if we did a CBC. This is what the slide of a sputum quantitative assay looks like. We could have 4 types of inflammation based on the sputum assay, which are eosinophilic when there are more than 3% eosinophils with a normal total cell count. We could have neutrophilic if the counts were 65% with or without an increased total cell count, a combined type of an airway inflammation, and a postgranulocytic where we would get normal cell counts. These are the things that we could see in sputum, and these are the biomarkers which would help us understand the underlying mechanism and treat the patient accordingly. So here we are. If you have an eosinophilic bronchitis, simply increase the inhaled corticosteroid dose. Do not add an antibiotic. If we get a neutrophilic bronchitis, we do not increase the ICS, we just add antibiotics if the total cell counts are high and recheck to see if there is any masked neutrophilia or eosinophilia in the cells. When there is no inflammation but an airway hyperresponsiveness in patient is present, we would like to do a SABA or a LABA test and decrease the corticosteroids. This is data from my own lab where I tried to endotype inflammation by looking at the blood eosinophil counts, and absolute eosinophil count of more than 300 were described as a patient being eosinophilic. People who had an eosinophilic inflammation going on, whereas 36% when the non-eosinophilic patients were tested. But when we tried to find out if the results were similar in the sputum assay, it was not so. We can see that the neutrophilic counts have gone up to 59% and the eosinophilic counts have now gone down to 26%. This being the reason for this being that the inhaled corticosteroids that we give our patients reduces the apoptosis of neutrophils and they remain in the circulation and their count becomes higher than what is expected. By saying this, what I mean to say is that we have to decrease our inhaled corticosteroid doses that we give our patients unnecessarily. There is very little concordance between the sputum and blood eosinophil counts. We can see that you could have a high blood eosinophil counts, but low sputum eosinophil counts, and again, the vice versa. So tests need to be done. We cannot simply guess what the type of inflammation for the patient is without testing. I keep on coming back to this slide because this is the most important slide when we discuss asthma phenotypes. Again, it could be Th2 high, it could be Th2 low, or the B cell mechanism. And how do we understand? The B cell mechanism is understood by the presence of a raised serum IgE, blood eosinophil counts, if high Th2 is present, increased FeNO levels if there is ongoing inflammation is all that we can understand. We cannot say that the patient has a type of inflammations, eosinophilic or neutrophilic, by simply testing the FeNO. Sputum assay, again, high T2 or low Th2. This brings us to another patient's history. Let's see if we can put that information into this patient's history and investigations. 53-year patient, exertional shortness of breath, even on daily activities, recurrent exacerbations to the point that it was 4 in the past 1 year, FEV1 1.2 liters, FVC 2.78. Patient has been on high dose inhaled corticosteroid and even oral corticosteroids almost the full year, anti-allergics and bronchodilators without any improvement, remains symptomatic despite the above. When we did the investigation of blood, we found that the total cell count was 5,600, absolute eosinophil count 120, and a raised serum IgE level of 920 without any identifiable ongoing triggers. Sputum assay was postgranulocytic and imaging and echocardiography was non-contributory. So this patient had a postgranulocytic inflammation of the airways, which is a non-Th2 type inflammation with a raised IgE. So this is a B cell type mechanism of the airways. And the way we recognize them is by doing a serum IgE and allergen specific IgE. Having exhausted all the GINA 5 steps of therapy, the only thing that remains for this patient is to do either specific immunotherapy or add an omalizumab. Indeed, omalizumab has shown to be of use and reduce the emergency visits for patients with asthma, as well as improve the quality of life. So this 50-year-old gentleman, who's a never smoker, asthma since the late 20s, had recurrent exacerbations, 3 in the previous year, short courses of corticosteroid. The patient was allergic to dust and also had rhinosinusitis and nasal polyposis. The father had asthma and the 16-year-old son was just starting to be breathless with exercise. Treatment was with high dose of inhaled corticosteroids, bronchodilators, and a leukotriene antagonist. The patient had documented sputum eosinophilia once in the past, and the specialist, based on that, decided to maintain him on a low dose of prednisolone. Now, this is something that we all know that high dose of prednisolone is responsible for several complications such as glaucoma, osteoporosis, and the rest. And we would not prefer keeping patients on prednisolone. So when we investigated further, we found that the pre-bronchodilator FEV1 was 1.6 liters, whereas the post-bronchodilator was 1.9. So this means a 300 ml improvement. The HRCT scan was normal. The serum IgE was again normal. Absolute eosinophil count in the blood was 0.3 per microliter. But the sputum assay showed that the patient had a total cell count of 9 million cells per gram of sputum, which was 60% neutrophils and 10% eosinophils, which is high, and an exhaled NO of 45, which is again a borderline high. So this patient belonged to a high Th2 level, no doubt. What do we do next? Because this patient has again exhausted all these steps of GINA. So we have to consider biologic in the patient, and then it doesn't take much to understand that it would be an anti-IL-5. So there are two types of anti-IL-5 available in the market. One is the mepolizumab, which inhibits the IL-5 per se, and the other one is benralizumab, which inhibits the receptors in the body. So summarizing, asthma is heterogeneous. A knowledge of biomarkers and endotyping is required to prognosticate or formulate specific treatment strategies, which is personalized medicine. The commonly used biomarkers are total and allergen-specific IgEs, eosinophil counts in the blood or sputum, and a mechanistic approach aids in accurate endotyping and adopting the correct strategy of treatment of the patient. We could use something like this, understand the clinical phenotype, match it with the biomarker, and then we will have the medication which we need to offer the patient. With the clinical phenotype of atopy, reversible airflow obstruction, a raised IgE and eosinophils anti-IgE would be the drug of choice. Atopic with mucus hypersecretion and airway hyperresponsiveness, which are raised FeNO and serum periostin anti-IL-13. We do not have this periostin with us at present. Severe asthma, frequent exacerbations with raised sputum eosinophils, blood eosinophils, anti-IL-5. Atopy with rhinosinusitis, aspirin sensitivity, sputum eosinophils high, we could give leukotriene antagonist or CRTH2 drug. Responsiveness, normal sputum is what we phenotype patients as those getting bronchial thermoplasty, and severe asthma without infections, sputum neutrophils, anti-CXCR2 would be something we could consider once the FDA approves this. Thank you very much.
Thank you so much, Dr. Dasgupta. And we are running quite late, and we have to now with the last presentation on occupational allergy and asthma. I request Dr. Rao Chaudhary to just precise the presentation so that we keep up to the time, because at the end we have to also do the panel discussion as well. So over to Dr. Sushmita Roy Chaudhary on occupational allergy and asthma. Dr. Roy Chaudhary.
Thank you. Thank you, Dr. Jaffrey. Let me just try and share. Can you see my presentation?
Yes, absolutely.
Okay. So thank you
Please
for
go
that. So I'm going to try and rush through the slides, just dwell on what it is. Occupational asthma, we know, is a form of work-related asthma, which is characterized by variable airflow obstruction, airway hyperresponsiveness, and inflammation attributable to a particular exposure in the workplace, not due to stimuli encountered outside the workplace. The significance is that nearly about 15% of asthmatics can actually have worsening of their asthma because of occupational exposures, and failure to diagnose and manage promptly can lead to long-term irreversible sequelae. Now, it can be classified as work-related asthma in three ways. The number one is sensitizer-induced occupational asthma, which can be because of triggers that are of high molecular weight, low molecular weight, and sometimes unknown. Irritant-induced occupational asthma, which is also quite commonly known as RADS, and aggravation of pre-existing asthma by the workplace exposure. These differences need to be known because that is how you will classify what the patient has. So approximately 400 occupational agents are currently documented as being potentially respiratory sensitizers, and they may cause either allergy, occupational rhinitis, or occupational asthma, and can be divided into high molecular and low molecular weight agents. So the common high molecular weight agents that we come across are proteins found in flour and grains, enzymes, laboratory animals, molds, and latex. Low molecular weight agents are isocyanates that are found in paints and some healthcare products, also in brushes, metals and acid anhydrides and cleaning products and disinfectants. Now, examples of workplace and typical occupational allergens are multiple, but the more common ones that we come across are those that work in the bakery industry, in the agriculture industry, where they have cow dander, pollen, storage mites, etc. And the list is unending. But as we go across, I'll talk to you about the prevalence that are more common. So animal breeders and handlers and plastic industry account for about 5 to 6% of occupational asthma. The more common ones are found in bakeries and in metal refinery, especially dealing with platinum, to the tune of 30 to 50%. Now, when we talk about work-related asthma, it can be induced by inciters, which are irritants and need to be in moderate to high levels, which cause previous asthma to be worsened, and that is what is called work-exacerbated asthma. Inducers, however, can be irritants, which can cause irritant-induced occupational asthma, but the most common occupational asthma is sensitizer or allergen-related, and this can be in small to moderate amounts, and with increasing frequency can actually worsen the amount of asthma that causes when the patient is exposed. And we'll talk about it. So this can be either IgE dependent or IgE independent asthma. And the risk factors at the workplace exposure are that based on United Airway Disease, there is a strong interaction between occupational rhinitis as well as occupational asthma. Nasal congestion, sneezing, rhinorrhea, and or itching have been shown to be reported to develop before developing occupational asthma. So isocyanates, which are one of the more common ones found in healthcare dress irritant, but also can cause hypersensitivity pneumonitis, and that needs to be differentiated from occupational asthma, and all of them together can cause accelerated lung decline. So by sensitizing agents, the latent period of immunologic sensitization is very important and variable. Low levels then, once sensitized, can cause symptoms, and if IgE mediated, they may correlate with skin tests and in vivo tests, and is seen in minority of the workers. The latent period of each sensitizer is very different, can vary from some minutes to hours to a few days and weeks. And the sensitizing potential of an aeroallergen completely depends upon the workplace exposure frequency and the exposure intensity of the trigger. Now, how is it different to RADS? In RADS, there is no previous history of asthma, but when there is a high level of exposure to toxic or an irritant, respiratory symptoms can develop within 24 hours of exposure, with persistent respiratory symptoms even after they have been removed from the workplace, and increased non-specific bronchial hyperreactivity. The pulmonary function of these patients can be normal but can show bronchial obstruction, but it is less reversible than sensitizer-induced asthma. And on bronchial biopsy, eosinophilic infiltration is not characteristic. Overall, it has a worse outcome. So it needs to be differentiated again. Pre-existing asthma, I won't talk about it much because my previous speakers have spoken about it, but is reported in more than 20% of asthmatics in primary care setting, and the management includes optimizing asthma control and may require work exposure to triggers to be taken away and move to cleaner areas. Now, at workplace exposure, the damage to the bronchial system and the upper airways depends upon the properties of the substance that you're being exposed to. If it is more water soluble, and if the patient's responsiveness is higher to the product, the concentration of the substance is high, and the duration of exposure is also high. These are decisive factors in causing long-term bronchial problems. So how do you diagnose occupational respiratory allergy? History plays a very important role and should be suspected in every adult with new onset asthma when they've joined a new job. And it is usually in connection with the workplace important. Even more important is remission or improvement during weekends and holidays. Rhinitis often accompanies, but it is not always necessary that they will have it. And specific inhalation challenge test in the laboratory under controlled conditions is considered to be the gold standard, but often very difficult to do. So the clinical history must include circumstances of the onset of asthma symptoms, severity and persistence and clinical course of the asthma, and temporal relationship between exposure at work and the disease exacerbation. Definitely know the known triggers and intercurrent factors of asthma, whether they are persisting at work or not, and that excludes occupational asthma. Identify other risk factors such as atopy and smoking habit, and definitely take a focused occupational and environmental history. Before labeling it as an occupational asthma, please rule out other asthma mimics. Also, if there are existing factors such as smoking, whether the patient is on certain non-selective beta blockers or NSAIDs that could be worsening previous asthma, whether they have gastroesophageal reflux, or they have onset of upper respiratory infection during symptoms or not. So review medical records wherever possible. So apart from these and physical examination, the lab tests that can be done are provocative tests like a non-specific methacholine challenge test or a bronchodilator responsiveness test, determination of IgE-mediated sensitization by skin prick testing, serologic specific IgE testing, and sometimes in non-IgE basophil activation testing, which is not very easily available. Other specific tests we have been discussed by other speakers of spirometry, pheno, and sputum eosinophil levels. And objective testings may also require work-related changes in peak flow by the individual before they enter work and after entering work after a few hours. So immunologic assessment, as we said, is skin prick tests for high molecular weight agents can be done. In vitro tests these days are quite easily available, including RAST and CAP and ELISA tests. Reagents can include whole natural extracts, purified allergens and recombinant allergens, but the purity of these can't always be catered for and are sometimes difficult to achieve. The IgE positive predictive value of IgE related tests is quite high in intracutaneous and skin prick tests to the tune of 90 to 93. So in the setting of a patient working in a certain environment, an IgE testing specific for that product being positive is quite high in determining the patient having disease. But even more simpler to do is monitoring of peak flow. PC20 obviously is not that easy to do because you have to do provocative tests every time. Peak flow monitoring before and after work and on holiday monitoring gives a very good inclination. So if FEV1 change is 20% or more is defined to compare with the control mock exposure day to define work-related asthma, and a 3.2-fold change in pre versus post-challenge of PC20 can suggest occupational asthma. However, a negative challenge does not entirely exclude the diagnosis because you could have used the wrong agent. There could be loss of sensitization over a time of exposure, and there could be mixture of antigens that are not replicated in the challenge, and the patient might have taken medication before it. Specific inhalation, as I said, is very good and a gold standard, but multiple challenges are required, which is time consuming and expensive and is not always available. The relative contraindications for specific challenge are if the patient has unstable asthma, is unable to withhold their asthma medications, and are unable to perform the tests. So how do we manage? The primary prevention is the best way to deal with non-cases of allergic disorders, and accurate diagnosis is the key to best management. Best prognosis is managed with early identification and removal of trigger. Most places will employ immunosurveillance programs to periodically evaluate the health of workers in the workplace and implement appropriate interventions to prevent recurrences or new cases, which can be done by itemized questionnaires, by performing spirometry and testing for non-specific bronchial hyperresponsiveness. These days, ELISA tests, as I said, are much more easier to do. The challenges and limitations are that they are based on non-randomized studies, and there can be individual variability of exposure in most patients. So reduce and avoid exposure in workplace, remove the worker in some cases, particularly if sensitizer is present. Medications should be optimized, and the patient should be considered as a sentinel event in a workplace. The prognosis is if timely removal should result in improvement. Some residual disease may remain in those who have been exposed to isocyanides, red cedar wood, etc. And it is worse if the patient continues to have longer duration of exposure with greater severity and frequency of symptoms and airway obstruction or hyperreactivity with dual bronchial responses. So in summary, please take into account your patient's environment, as Hippocrates said a long time ago, and also ask about what their occupation is. And history is key to suspecting occupational asthma. Use objective measures to confirm diagnosis and focus on prevention, which is the best management in addition to managing asthma as you would. Thank you for your patient hearing.
Thank you so much, Dr. Sushmita Roy Chaudhary. You have really taken very little time and completed the session. Thank you for helping us out. We had a very good, excellent presentation, almost 6 presentations. We started with Dr. P.A. Mahesh on epidemiology, which has said that asthma in childhood and adulthood are continuously in increasing trend. Dr. Gayatri Pandit has spoken very well on allergic and non-allergic rhinitis. Dr. Neeraj Gupta has spoken on pediatric asthma and rhinitis, and especially specific cases. Dr. Christopher has spoken on adult asthma, on smart therapy very well. Dr. Das Gupta has spoken on phenotyping and is very specific talk by Dr. Rai Chaudhary on occupational allergy and asthma. Now, we should start the panel discussion. We have completed all the presentations. So let's over to all faculties. Dr. Christopher, please unmute yourself. Dr. Gayatri, you also unmute. Dr. Mahesh, you have to also unmute. And we can start the panel discussion, right? Dr. Shoaib Mitra, would you like to add something?
No, I think this module today was very excellent talk by all the faculty members we had. And so you have very rightly summarized the entire thing. So I think we can quickly go into the question answer sessions. And then after that, we can end this module today. So there is, I think, one question in the chat box, that is any role of tryptomer or amitriptyline in allergic rhinitis. So we would like to give this question to Dr. Gayatri Pandit. So, and may I request Dr. Pandit to answer this question. It has been posted by Debolina Shukla.
No, sir. By guidelines, there are no specific roles of tryptomer and amitriptyline in allergic rhinitis. We have not found, we don't use it in management of allergic rhinitis.
Can it be used for rhinomotor rhinitis?
No, vasomotor rhinitis, especially for a vasomotor rhinitis, the combination with an azilastine molecule is found to be quite beneficial to start with. And in cases where there has not been any relief with a medical line of a management at all, what we are doing is a posterior neural resection in some selected cases who have not responded to any medical line of a management at all. Earlier time, it used to be a medial neurectomy, but that again we came across with a problem of a dry mouth, the other adverse effects of a surgery. Whereas in a posterior specific where we, kind of cauterize only that part, we don't come across. So otherwise, in an amitriptyline and tryptomer, we have not used much in an allergic rhinitis. I would like to hear from other panelists if they have used so.
Yes. Does any other panelist would like to add something? Okay. So, then there's another question, that is about the mepolizumab in asthma, when to advise. So, Dr. Gupta, would you kindly answer this question?
Thank you for giving me this question. The patient, the ideal patient who would benefit from mepolizumab is the patient in whom the IL-5 is the driving mechanism of asthma. Like I have been reiterating in my discussion today, that there are two specific types of inflammation. One is a high Th2 type and the other one is the high Th1 type or the non-Th2 type. Mepolizumab being an anti-IL-5 would work in the patients who have a high Th2. And how do we understand that these patients have high Th2? Is by measuring the blood eosinophil counts or the sputum eosinophil counts. These two markers are the most important to understand the prognosis and the therapy of patients with mepolizumab.
Thank you, Dr. Das Gupta. I think this was very clear what you stated. Okay. So there is still, this question is still coming up. I think it was well explained by Dr. Neeraj that what is the minimum age and that the suspension Montelukast can be prescribed, what is the maximum duration for which it can be safely prescribed. Dr. Neeraj Gupta, please.
So as per the literature, Montelukast can be given at a minimum age of 6 months onward. So this is the first thing. But we need to remember that now the recent guidelines, even the GINA and the other bodies, they say that Montelukast should not be prescribed as upfront drug for any of the respiratory allergy condition. And even if it is prescribed, it should be used as an add-on drug, as a second or a third add-on drug, not as a first drug. And now people are trying to refrain from using Montelukast because of the FDA warning related to some neuropsychiatric manifestations, and that is why it should be refrained. Though there is no mention about any upper duration limit of Montelukast use.
Thank you, Dr. Neeraj Gupta. So there is one question by one of our faculty, Dr. Angira Dasgupta. Does anyone use nasal inflammation measures, nasal anti-inflammatory measures? I think you want to ask that, Dr. Dasgupta, for treatment in allergic rhinitis. Dr. Gayatri Pandit, please.
We don't have any specific markers as such in measuring allergic rhinitis inflammation. What we would actually do it is by in Carrot scoring sometime, where we have a clinical scoring system and something called as a SNOT scoring system when it comes to rhinosinusitis. But we have definitely some inflammatory markers that we study when we take a biopsy in polyp patients. So in a polyp patients, we look in for an eosinophil counts per high power field, which is less than 10, up to 10 and 10 to 100. And these are, considered as in severity of the symptoms in our CRS with polyp patients, in particular to, allergic inflammations in polyp patients.
Dr. Jaffrey, would you like to say something in this matter?
See, I'm from a chest side, so I'm not using it, but definitely we are using eosinophil count in blood, and we are also doing total IgE estimation, and this is how we classify a patient is more neutrophilic inflammation or eosinophilic inflammation, and as per that the treatment is basically decided. But basically, one very important thing is eosinophil counts vary depending on the treatment, especially if the systemic steroid is used or intranasal steroids is used, eosinophil count goes down. So that is also one thing which is to be kept in mind when we are treating a patient. There is a very good question asked by Dr. Neeraj Gupta in children, that is sputum eosinophils are practically difficult. What is the utility of ball eosinophilia? Right. So anybody who has an experience of doing a eosinophil count in bronchoalveolar lavage? Would you like to comment? Anybody has such experience?
Dr. Jaffrey, we do not do that in asthmatics. I'm talking about adults.
Right.
But we do differential counts in ILD and other situations. So technically, you can do it in a child, but to do the bronchoscopy and lavage purely for the purpose of obtaining differential counts may not be accepted by many parents and also by some of our colleagues. So I think we should use that in the more extreme situation when we are very pressed for diagnosis.
So, and when we have a surrogate marker of blood eosinophils, so I think that is much easier to be done, and that we can, and if we need to phenotype the patient depending upon the severe asthma in children.
And Saibal, when we talk of BAL, we are mainly looking at an alveolar, not a bronchial sample.
Yes.
Are better than BAL, but being fairly invasive, non-invasive measures would be ideal.
Also, doing that sometimes can actually worsen your airway inflammation and airway hyperresponsiveness unnecessarily. But we do it sometimes in hypersensitivity pneumonia patients, and some of them who have bronchial involvement will show raised eosinophils in the acute setting.
Okay.
One of my question to all of you, like we are seeing COVID-19 since last 2 years, and my observation in my patient was like a patient who has suffered from COVID-19, they who were stable on bronchial asthma or even who were on allergen immunotherapy, and they were doing they were quite stable. They were using they had a minimal symptoms. After COVID, few of the patient has aggravated. This asthma has aggravated, their rhinitis has aggravated. Anybody, you have observed this thing?
Absolutely, sir. Same observation, sir.
Right, great.
Especially with the immunotherapy, people who were doing very well with an immunotherapy and where their maintenance dose was quite stable for a very long time, that I have definitely found a disturbance following post-COVID. So we had to really decrease the dose and then get them back to their maintenance.
True.
Yeah. Post-COVID asthma is definitely more worse. It's just like another viral exacerbation that's actually taking the asthma control away for a lot of patients.
True, but the exact mechanism is yet to be understood.
Yeah.
Because the patient has stabilized, like COVID has gone away, and even after 6 months or 8 months, we are seeing the patient has become symptomatically very bad.
Yeah.
Gone back to the similar situation when he came on the visit. So this is a good area for clinical research.
Sir, what we have seen or observed is that in the post-COVID era, definitely we have seen a surge in the allergic disorders. We have also seen a surge in some other disorders like which were not there so prevalent, like tuberculosis. Like in past 6 or 8 months, we have seen so many cases of tuberculosis, which probably we have not seen in equal years, like 6 or 8 years. So what we feel is that COVID has definitely done something to the immunological system, to the immunity, and now means like the diseases which were like controlled by the immunity, and they are now once again resurging. Like in pediatric population, we usually give the BCG, and now we feel that probably it is the reactivation of the primary focus which is probably creating the problem more in the pediatric population, which is happening. So there is something there which is related with the immunity. Dr. Soebel might be able to tell us better about the immune system. Not sure.
Yeah, means that is a very complex thing. So in the post-COVID and those patients who had, because now there was initially this concept that any viral infection will lead on to the increase in the Th1 inflammation, and that will suppress the Th2 inflammation. But now we know that in the COVID scenario, this is not always true. It can lead on to the rise in all the pan-inflammation because of the increase in the pan-inflammatory cytokine like the IL-2 or maybe in some cases IL-6 also. So which can lead on to the increased airway inflammation, which extends to all entire airway. And as there is an increased airway inflammation, which could be neutrophilic, which could be eosinophilic, it does not matter. But increased airway inflammation, it leads on to the increased chances of having the symptoms because of the environmental triggers. Okay, so may I ask something to Dr. Mahesh? I think Dr. Mahesh, you have shown a very interesting slide where it was shown that though there is over a period of time, there is a decrease in the oxides of sulfur oxide and the NOxes which we talked about, and oxides of nitrogen, but still the asthma is rising because what it has been shown. So do you think it says that because asthma is rising maybe because of the other elements of the traffic related air pollutants, and perhaps like or it is something else? Maybe, what do you think that? How?
No, I think we looked at, I think NO2, SO2 and particulate matter. All of them had reduced because of the legal changes, and the traffic had actually come down. However, the prevalence of asthma went on increasing. So pollution definitely worsens existing asthma, but the prevalence of asthma and pollution is still an unanswered question. So as I looked at, as I shared one of the slides, the effect of pollution on asthma is also mediated by the BMI. For example, people who are obese, people who are underweight, both are at higher risk of on the onset of asthma as compared to children with normal BMI. So there are a whole lot of factors that may be influencing increased prevalence of asthma, and not just pollution.
Yes. Yes.
So,
Yes. So maybe, yes.
What we looked at was outdoor air pollution. There is also indoor air pollution. There is diet, there is stress, there is physical activity. So I'm sure all of these also are having a bearing than just the air pollution.
Yes.
So it is not a linear correlation.
Because the other factors may be
It's
also
a very complex interplay of a lot of factors.
yes, or maybe the changing lifestyle, like the hygiene hypothesis, like we are more cleaner environments that people are staying, and so it is causing.
Correct. Exactly.
Thank you.
Yeah,
Okay,
sure.
Dr. Rafi, would you like to ask anything to panelists? Because I don't see any more questions in the chat box. Okay, there is a question that's come up that BCG activation, please elaborate. Okay, by Dr. Jitendra Bal. Okay.
It's not the BCG activation. It's basically the reactivation of the primary complex, which I wanted to say. Not the BCG activation. It's a primary complex reactivation, which I wanted to say.
So is this question is by you, Dr. Neeraj?
No, it's not me. It's by Dr. Jitendra Bahal who was asking this question.
So he is about BCG activation. Means what? How does it correlate with the today's allergy module?
No. Basically, like I was mentioning about the resurgence of tuberculosis also post-COVID. So
Right.
in context of that, he is asking.
Okay. So okay, I think his question is answered by you. I think this was something.
This question is answered. Right.
Yes. And so yes. Okay. Okay, so can we just sum up the entire thing and end today's module, Dr. Jaffrey?
Dr. Saval, I think you would be the right person to summarize the whole this thing, right?
Okay,
so over to you.
Okay, thank you. So I would definitely thank all the faculties for giving such a nice presentation and making this module a very good learning module for all who had attended it and who would be seeing it later on. And thank you very much, Dr. Jaffrey, for moderating the entire session. So today's module was basically on the nasobronchial allergy, where we discussed about the various aspects of the allergic rhinitis and asthma, and also the occupational asthma. We have 2 more modules left, where we would be mainly discussing about the other spectrum of the allergic diseases, like mainly food allergies, the drug allergies, the insect venom allergies, and then we would take up the allergy and immunotherapy, which is an important treatment modality in the treatment of the allergic diseases. So in today's session, we learned about the epidemiology of the allergy, rhinitis, and asthma, how it has been changing over a period of time. And then we learned about the allergic rhinitis and how we differentiate from non-allergic rhinitis and what are the treatment modalities. After that, we looked into the asthma in the children, which was very nicely stated by Dr. Neeraj Gupta, just based on a case as and how do we evaluate. Then we moved on to the asthma in adults, which was excellently presented by Dr. DJ Christopher, who mainly helped us in understanding that how the treatment modalities have changed and what the change in the GINA guidelines has occurred and what is the basis for that change. After that, the phenotypes in the asthma, this was lucidly elaborated by Dr. Angira Dasgupta, and she said that why it is important to phenotype the asthma for the personalized medicine and what are the factors is needed in phenotyping it and how it guides our treatment. At the end, we had a beautiful presentation by Dr. Susmita Roy Chaudhary on the occupational asthma, what are the types of the occupational asthma, when we should start thinking about occupational asthma, how we should evaluate it, and what are the major modalities of treating a patient of occupational asthma. thank you very much. I thank you all, and I thank Dr. Jafri for moderating the entire session, and also I thank Sanofi for helping us in getting this entire module in table, and which was under the Indian Chess Society. So we look forward to have the 2 more modules done maybe in the next 2 months, when we complete the entire module on the allergy and the immunotherapy complete. Thank you all. Have a good night.
Thank you,
Thank
everyone.
you.
Good
Good
night.
night.
Thank you very much.
Thank you.